कोविशील्ड सर इधर लगा है।
उधर कोविशील्ड लग रहा है, तुम्हें लग
हाँ
गया?
हाँ लग गया, मेरे को तो लग गया सर फर्स्ट शॉट।
मैं
एम्स
तो अभी डर ही रहा हूँ।
मैं भी नहीं लगा
पटना कोवैक्सीन और इधर कोविशील्ड है।
मेरे को सुइयों से बहुत डर लगता है।
Hi, Dr. Muscati, sir.
Hi.
Hello, sir.
गुड इवनिंग सर।
Hi,
Good
Kuresh.
good evening.
You are the only one who's come dressed
Yeah.
for the meeting.
Very nice. Nicely dressed. And then Dr. Rishi is also there with.
अरे मैंने भी टाई पहनी है भाई, क्या मतलब?
हाँ हाँ, उन्होंने एडिशनली एक ऊपर ब्लेजर भी डाला हुआ है।
वो बॉम्बे में है ना, वहाँ ठंड ज्यादा है।
I'm just putting in my slides.
Yeah.
So we are live.
Okay. A very good evening to all of you. We welcome you all in this webinar on update on ocular surface disorder under the aegis of Indian Society of Cornea and Kerato Refractive Surgeons, that is ISCRS. And it's a great pleasure to have you all here, and I would just like to inform one and all who all are with us right now in this meeting. We have with us our president of ISCRS, Professor J.S. Titial, who is the professor and head of the Cataract, Cornea and Refractive Surgery Services at RP Center, AIIMS, New Delhi. And he doesn't need any introduction. He has numerous publications, huge experience in the field of phacoemulsification, the field of cornea and refractive surgery. And he has received many awards, including Achievement Awards and Senior Achievement Award at the American Academy of Ophthalmology, and the most coveted Padma Shri from Government of India by the President of India.
We have with us Professor Rajesh Sinha, the man behind the ISCRS, Honorary General Secretary. He is Professor of Corneal Lens and Refractive Surgery Services at RP Center, and he has over 350 publications, 4 textbooks, 5 educational manuals, and part of 3 multicentric FDA clinical trials. He has various awards from notable societies such as the Achievement Award by American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology, and SARC Academy of Ophthalmology. And he also holds the coveted position of the Treasurer of All India Ophthalmological Society, as well as the Eye Bank Association of India.
We have with us Professor Namrata Sharma, who is also a co-moderator in this session and the chairperson of the scientific committee of ISCRS. She is a professor of ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center, AIIMS. She is also the General Secretary of All India Ophthalmological Society and the Regional Secretary of Asia Pacific Academy of Ophthalmology. She is also Secretary of Eye Bank Association of India, and she has numerous publications to her name, more than 380 publications in various peer-reviewed journals. And she has many chapters, and she has authored as many as 11 books. So that's a huge number. And she is actively involved in teaching of undergraduates as well as postgraduates, and has been part of many scientific and academic activity.
It is a pleasure to introduce Dr. Rajiv Mukherjee, Treasurer of ISCRS, who has been involved with the inception of ISCRS as well right from the very beginning. He is Director and Senior Consultant, Mukherjee Eye Clinic, New Delhi. He is a visiting professor at Feinberg School of Medicine, Northwestern University, Chicago, USA. He has established himself in the field of cornea and phacoemulsification, presented numerous papers and courses at international and national levels, and he is the Vice Chairman of Family Benefit Scheme, All India Ophthalmological Society.
It gives me great pleasure to introduce Professor Amit Gupta, who is working as professor in the field of cornea, cataract and refractive surgery services at Advanced Eye Center, PGI, Chandigarh. He is also the Senior Vice President of Chandigarh Ophthalmological Society, Honorary Secretary of Eye Bank Society, Chandigarh. And he has numerous papers and publications, particularly his area of special interest is role of femtosecond to perform corneal transplants. And he has been invited in many conferences, both nationally and internationally, and has numerous publications to his credit, and is a reviewer for several international and national journals.
It is a pleasure to introduce Dr. Ajay Dave, who is a Director and Senior Consultant, Cornea and Cataract Center at Delhi. He has done his MS ophthalmology from King George's Medical College in Lucknow and pursued 2 specialized fellowships at Shankar Nethralaya in General Ophthalmology, Chennai, and second in cornea and external diseases at Southwestern Medical Center in Dallas, Texas. His areas of interest include cornea transplant, cataract surgeries, and laser refractive surgeries. He's actively participated in conferences, workshops, and seminars, both as speaker and faculty member, and he's lectured extensively all over India on the subjects of dry eye, cornea, external eye disease, and he is also one of the founding members of the ISCRS.
We also welcome our dear friend Dr. Amrish Darak, who is the Medical Director of Vision Next Foundation Eye Hospital, Pune. He's a prolific refractive surgeon. He has huge loads of experience, more than 20 years of experience of working on all sorts of refractive suites, all sorts of refractive surgery machines. And he has presented many papers and courses at international and national level. And apart from his ophthalmological interests, he's also a film producer. So it's, and of course, he's a very dear friend.
It is a pleasure to introduce Dr. Nilesh Mohan, our own RP Center alumnus. He's currently the additional professor and in charge Eye Bank of Regional Institute of Ophthalmology, Indira Gandhi Institute of Medical Sciences, Patna, and he's been involved in restructuring the whole of Regional Institute of Ophthalmology, which is going to come up in its modern avatar. He has a post-PG 21 years of experience in ophthalmology. He was the pioneer in establishing the first eye bank in the state of Bihar at RIO IGIMS in 2014 and performed the first corneal transplant surgery in Bihar in October 2014. He was the organizing secretary of our 9th annual conference of the EBI at RIO in September 2017, of which we have wonderful memories. He continuously imparts training at RIO to fellows and trainees. He also holds positions of Treasurer Bihar Ophthalmological Society, Secretary Patna Ophthalmological Society, member East Zone Eye Bank Association of India, immediate past editor Bihar Journal of Ophthalmology, and he has been credited with many publications in national and international journals. On the lighter side, he sings extremely well and also is fond of listening to music.
Now we will introduce the people who are going to do real hard work today of giving all the talks. And in the forefront we have the Vice President of ISCRS, Dr. Rishi Mohan, who I mean, it's always a great pleasure having him on the in any seminar or a webinar. And he did his initial training in Maulana Azad Medical College. He did his MBBS and got a gold medal in ophthalmology. And since then, he has great interest in the field of ophthalmology. He did his MD ophthalmology from RP Center, then went on to do DNB, FRCS, and MAMS. And then he also did a 5-month training in phacoemulsification from Prince Charles Eye Unit, King Edward VII Hospital, Windsor, UK in 1994. He was awarded the membership of Academy of Medical Sciences in 2006. He has received numerous awards, as I said earlier, which includes the Best Resident Award at RP Center. And he has held various positions. He has been Secretary of ORA at RP Center, Joint Secretary DOS, Member Scientific Committee AIOS, Secretary of Indian Society of Cornea and Creative Refractive Surgeons, and also the Treasurer of Eye Bank Association of India. Currently, he has been member of Scientific Committee of AIOS, member Managing Committee AIOS, Joint Secretary of Eye Bank Association of India, President DOS, and currently he's the Vice President of ISCRS.
It is a pleasure to introduce my very good friend, Dr. Bhaskar Srinivasan, who's done his MBBS from TN Medical College, Mumbai, and MS from AFMC, Pune. He was inducted as a fellow in cornea and refractive surgery at Shankar Nethralaya in 2002 and has been there since that time. His present position is Senior Consultant Cornea Refractive Surgery, and he's also the Global Ambassador of the TFOS group. His interests are ocular surface disease, and he's done some path-breaking work as well as very important work in keratoprosthesis, lamellar corneal surgeries, and he has more than 65 publications in the peer-reviewed literature.
It gives me great pleasure to introduce Dr. Quresh Maskati, who is an eminent cornea surgeon who introduced the initial in the initial days of keratoprosthesis when we were doing it was being done in India. He was the one who is a pioneer in this field. He is an eminent cornea surgeon. He has been president of Cornea Society of India. He has held various other posts, notable among which, apart from the CSI, is the All India Ophthalmological Society, wherein he was the president for the year 2014-15. He is also the chairman of Family Benefit Scheme, and he has been the president of International Society for Manual Small Incision Cataract Surgery. He has been the president of Bombay Ophthalmic Association and also the president of Maharashtra Ophthalmic Society, and currently the vice president of CSI, and has been very active in academics in the field of cornea and cataract.
Gives me great pleasure to introduce Dr. J.K. Reddy, again a very good friend from Shankar Eye Center, Coimbatore. He's the chief of the cornea clinic and the director of the technical aspects. He has huge amount of surgical experience, 50,000 cataract surgeries, 3,000 transplants, 6,000 LASIK surgeries, 500 pediatric cataract surgeries. More importantly, he's known for his innovations, which many of us have co-opted and which have changed the way we do our clinical practice. He's presented papers in ASCRS, American Academy of Ophthalmology, APO, MIACO, WOC, APCRS in USA, Singapore, Moscow, Hong Kong, Riyadh, Bahrain, Abu Dhabi, Malaysia, Beijing, Nepal, Nigeria, Cambodia. I don't think any city on the global map is left. And that is more so because of his innovations, which he comes out periodically with in cataract, corneal diseases, and glaucoma. And I think he's never aging because ever since I've seen him, he's looked pretty much the same, looked resilient many years ago and still looks like one. So welcome, Dr. J.K. Reddy.
So before we actually begin the webinar, I will request the president of ISCRS, Professor Tityal sir, to speak a few words.
Thank you, Rajesh. It's a wonderful evening for all of us listening to people who have such a wide experience, not only in a subject which we are going to discuss today, which is so important, the ocular surface disorders, especially looking into a corona pandemic and people using masks and working at home with various systems. Dry eye is a serious concern at this junction also. But I'm very hopeful that the panelists we have today, they have a huge experience. And the speakers, as you rightly pointed out, they are the one who have worked in this particular field, and their experience and their knowledge will be a definite beneficial to audience which are connected with us. And for me personally, ISCRS is doing quite well. This is our continuous medical education, which is going through ISCRS, not only in terms of refractive, cornea, cataract, but ocular surface also. And thank you both, Professor Rajesh and Professor Namrata Sharma, for bringing this particular subject. And thank you again, the sponsor, Santen, which has really helped us to get into this particular forum. I wish you all the best for all the panelists and speakers. Let's have a good discussion today. Hope that people who have joined us, they will benefit largely with our the discussion part. Thank you again. Let's begin the show.
Thank you, sir. And it's great pleasure to start the show with our Vice President, Dr. Rishi Mohan, and he'll be talking about the mimics of ocular surface disorder. We do have certain conditions which can mimic ocular surface disorder, can appear like that, but it may not be the same. So let's have his opinion on that. Dr. Rishi Mohan, please.
Thank you so much, Dr. Tityal. Can you all hear me?
Yes, sir. We can hear you. We can see your slides.
Thanks, Namrata. Thanks, ISCRS, for inviting me and making me the opening batsman here for this very important discussion. So the topic that was allocated to me was to try and see if we can identify some of the mimics that try and masquerade as dry eye. And I thought I would just call this trying to catch the thief and identifying the mimics. I have no proprietary or financial interest in anything that I'm going to be speaking about over the next few minutes. So the aims of the assessment in a dry eye is to ascertain whether it is a dry eye or something mimicking a dry eye, and then to ascertain the cause and the type and the clinical severity, and then to obtain baseline evaluations for future comparisons and also to gauge the efficiency of treatments. So is it a dry eye? So there is a host of conditions that can mimic a dry eye, and these are just some listed along with some represented photographs. The ones that are the more important ones I will dwell on for a little longer. But just to make a list, which is of course not exhaustive, is conjunctivitis, allergic eye disease, infections such as trachoma, epitheliopathies, SLKC, and the process begins with looking at the complaints very carefully, going on to pick up the relevant points in the history, then to make certain general observations, and that would include a general physical exam. You don't have to jump to the slit lamp straight away, and then of course a detailed ocular exam. So the symptoms usually are burning, foreign body, dryness of the eyes, redness, grittiness, irritation, heaviness, inability to open, stickiness, tiredness, blurring. So pretty much any of the ocular systems can fit into a dry eye syndrome. The clinical signs we'll deal with in much greater detail in the next few minutes. The history, one must look at what are the exacerbating conditions that could have produced these problems, the kind of sleep, the computer usage, whether he wears glasses, what are the other ocular disorders, whether he uses contact lenses, whether there's any smoking or alcohol intake history, and the medical history of surgeries or medications or any other endocrinal problem that that patient may have had, any autoimmune or dermatological disorders, any known instances of injuries or known cases of allergies. So keeping one's eyes and ears open as one interacts with this patient is very important. So look at the face and the scalp, the expression, the blink rate, the quality of the blink, the joints, the skin as he walks up to the slit lamp, whether he wears contact lenses, whether he's had a previous refractive surgery or other ocular surgeries for that matter, what are the medications he's been on, and whether he's had any inflammations. And the one that Dr. Tityal just mentioned just in his introductory remarks was what is relatively new and probably related to the excessive use of masks in these days, or what we are now calling as mask-associated dry eye or MAID. So the diagnosis of dry eyes will start with a physical and an eye exam, observation of joint deformities, look at the skin, the scalp, the examination of the eyelids, slit lamp biomicroscopy, especially the nature of the mucus that is there, which is thick and stringy or rope-like, or is it plentiful or minimal? Is it clear or opaque? And looking at the hands and the face and the skin can give us lots of ideas as to what kind of a situation or condition we are dealing with. When we go into the slit lamp examination, start from the lid borders, the lashes, the debris and the tear film, any mucus strands, look at the meibomian openings and the oil droplets, the blink movement as we look at him, and any injection or hyperemia in the conjunctiva. Conjunctival changes again, the lack of luster on the cornea as well as on the conjunctiva can be a dead giveaway, as well as the presence of a superficial punctate keratopathy or filaments. The examination of the marginal tear strip here, which has been highlighted by fluorescent just for demonstration purposes, the presence of debris in the marginal tear strip, and the use of xeroscopy, which is essentially the assessment of a corneal reflex, and the non-invasive breakup time. The tear meniscus height is a very good way to look at these patients, and you can see the image on the right showing a very poor tear meniscus in aqueous deficiency. Ocular surface dye staining using either of the three dyes, aesthesiometry, which is something that has been described but is hardly ever actually practically used because of the lack of the equipment and the spread of the kind of values that one gets. And the Schirmer's test, which is again divided into three types: the basic secretion test, the Schirmer's 1, which is a assessment of both the basic and the reflex secretion. And we all know the normal, the subnormal, and the pathological values. of this examination. This is something that I use because the patient often comes back to me more than once. And when I have stained him, and you can see here a series of a normal patient where the first image on the extreme left and the last image on the extreme right is about 10 or 12 minutes apart. And one can see at the bottom how delayed the clearance is in a patient with a significant dry eye. And in fact, studies show that there is a much better correlation of fluorescent clearance rather than Schirmer's 1 with the signs and symptoms of dry eye. So this is something that has actually reduced the amount of Schirmers that I now do in the clinic because I'm relying more and more on this, as well as, of course, now with the available of the ocular surface analyzer, which helps us identify these patients of dry eye. So going specifically into the differential diagnosis of dry eye, there's blepharitis, viral keratitis or conjunctivitis, contact dermatitis, chlamydial conjunctivitis, pemphigoid, and flicked annulosis, rosacea, inflamed pingiculars, contact lens related issues and infiltrates, bacterial conjunctivitis, and conjunctivitis medicamentosa. So the symptoms of bacterial blepharitis are fairly straightforward. There's a lot of problems, and once you examine these patients and look at the lids, you can see the typical lid signs. In chlamydia, one has to avert the lid to be able to get an idea of what's going on, and one can see a mixed papillary and follicular reaction with the presence of a pannus, and there's often a palpable preauricular node as well. In flicked annulosis, you can have one or more of these raised nodular conjunctival infiltrates, which are actually delayed hypersensitivity responses induced by microbial antigens, mostly seen in the younger individuals. Allergic conjunctivitis, by far the most important of the differential diagnosis, and especially in a place like India and Delhi for that matter, where there's so much of pollution and there's so much of overlay and overlap between allergy and dry eye that these things often coexist. But itching is the single most important symptom that would suggest that there is a significant amount of allergic influence in these patients. So the diagnosis on history, family history, atopy, the presence of dye staining, the Schirmers, the tear meniscus, the BUT, and more sophisticated tests for allergy can help us differentiate these subsets with pure dry eye. Drug-induced allergic conjunctivitis with hyperemia and chemosis of the bulbar conjunctiva, allergic folliculosis as seen here, which is quite pathognomonic of medicamentation, and the toxic reactions to various kinds of antibiotics, antivirals, sympathomimetics, etc., and anesthetics or misuse thereof, and the marginal infiltrates of contact lens wear are very often part and parcel of our diagnostic dilemmas. Absence of blinking and severe dry eye, and you can see this very elegant video at the bottom given to me by Dr. Umang Mathur, where Botox has been used, and you can see that the lack of blinking is producing all the problems related to dry eye in this patient. Corneal anesthesia, we have a full talk on neural regeneration in this session by Dr. Quresh. So he'll probably be dealing more with this, but just essentially the interruption of the ophthalmic division of the fifth nerve results in a neurotrophic keratopathy, and there are various causes of this ocular sensory loss. And these are extremely difficult cases to treat because they create what we call neurotrophic ulcers and become extremely difficult to treat with their coexisting dry eye. It's also important to remember that all dry eyes are not dry when they present to you, and they can be paradoxical lacrimation, and one actually has to look at these patients very carefully to see the conjunctivochalasis and the other problems that can produce excessive lacrimation in the presence of a dry eye. So if one sees something like this and one has already tried pretty much everything, then are we possibly missing something? See the diffuse punctate keratitis going all across the cornea. And one must think of the medications that these patients are very often on when they are referred to you. And the preservatives pretty much here listed in order of their corneal toxicity should be looked at, and these medications must be stopped and replaced. So to summarize, dry eye is an extremely common problem that we face, and the detection and differentiation of the tear film abnormalities is a concern of each one of us. There is unfortunately no single predictive test, either in the clinic or the scientific era. but one can use these methodologies which are all available to us, which I have listed for you earlier. The one in the middle here is the ocular surface analysis. This as one machine gives me a lot of information, and this is something that's really helpful to me to cut down the amount of time that I need to spend with these patients to make a diagnosis. So thank you very much for your kind attention. Thanks very much.
Thank you, Dr. Rishi, for an excellent overview on the mimics of ocular surface disorder. We keep seeing such patients very often wherein there is always a doubt whether it is allergic, whether it is dry eye, whether it is something else. I will just ask Dr. Rishi if you can unshare your slides.
Let me.
I'll ask Amit Gupta, who is, who has been, practicing at PGI Chandigarh. What do you think about these mimics? I mean, how many times it can be detrimental also because you, are on the part of the treatment. So what's your comment on that?
Yeah, I think Dr. Rishi has very nicely summarized what all we are supposed to do. And a couple of mimics which are very challenging. One is the lid viper epitheliopathy and the floppy eyelid. Most resistant patients, they sometimes just don't get okay with the normal thing. And I do rely a lot on the OSDI, and that we treat the patient symptoms once it's on the phone. There's a program, and if you go for the ocular surface disease index, so what I do is I just hand over that to the patient, and they just have to mark. It gives us a very good starting point as to how aggressively we want to treat this patient. And I give a lot of importance to surface staining, and also determines the aggressiveness of the treatment. And when it comes to differentiating the whether it's allergic or dry eye, sometimes there's an overlap. But of course, we should look for these classical signs. Itching is there in these patients, so there's a bit of conjunctival chemosis, or if there's a little bit of pigmentation on the exposed bulbar conjunctiva, or if there's presence of papillae versus follicles. We've conducted a thesis on Demodex. A lot of these patients presented like dry eye. They had been treated as dry eye. They were not getting better. So sometimes we take out these few cilia and we send it to the lab, and we can see the presence of Demodex on these uh, on the lids. And of course, that requires ivermectin or petroleum jelly. So immediately our treatment will change. And many of these patients are very grateful for this.
Okay. Dr. Namta, you would like to say something on this?
So I would just like to highlight the fact in which Dr. Rishi Mohan has also highlighted that if you see VKC cases, then vernal keratoconjunctivitis, especially when they are active, they tend to have dryness. And also, if you see resolving keratitis cases as they resolve, the corneal ulcers as they resolve, especially when they heal, then also they tend to, have a little bit of dry eye component, and that also should be looked apart from all the features and all the factors that Dr. Rishi Mohan has mentioned so nicely.
I think that point is well taken. And Rajesh, even those with chronic allergy who had it for a while with the associated limbal stem cell problems, they all have a coexisting dryness. So the use of a lubricant then becomes part and parcel of their allergy treatment.
Tyal sir, you would like to comment on that? Like you have seen for years, you have seen many patients of contact lens who are contact lens users also and who develop some allergy as well as dry eye. So any comment on that?
I think Dr. Rishi has done a wonderful job for comprehensively covering the entire signs, symptoms, and workup of these patients. And we all know things coexist sometimes, especially if you look into people who use devices like contact lenses for a longer period. They're definitely going to have a combination of allergy as well as dry eyes. And such cases, the treatment, as Dr. Namrata was saying, has to be a combination. You have to tackle the allergic part also and tackle the dry eyes. And most importantly, some of the anti-allergic medications which people use, they do induce dryness also. So you have a double-edged effect of these medications. So you have to choose those medications which has less impact on a dry eye feature of a patient. So in that way, assessment is very, very important. And fortunately, nowadays you do have a lot of preservative-free medications which could be used along with the contact lenses. That will also decrease the dryness-related problems. And we have been teaching people like if they can use a disposable contact lenses, that will have a less impact to ocular surface. Or if they use lenses as per the given advices. Suppose you have a monthly disposable, they have to dispose the lens at month. So these are important points, but whatever said and done, now you have to look all the aspects, and ultimately it is the chronicity which we have to break, and ocular surface has to be saved.
Thank you, sir. Ocular surface disorder has been studied extensively, actually, and recently we had a report of TFOS dues to recommendations. Now, similarly, we have another recommendation and another, guideline, and that is the Asia Dry Eye Society guidelines. So we have Dr. Bhaskar Srinivasan with us, who will be talking about the Asia Dry Eye Society recommendations of what to treat, how to treat, when to treat, and how to diagnose. So, Dr. Bhaskar, all yours.
Thank you, Dr. Rajesh, and thank you, Dr. Namrata, for inviting me for this. Just a second. Is my slide seen?
Yeah.
So basically, I'll be covering what has been labeled as tear film oriented diagnosis and tear film oriented therapy. And this was a work which was published by the Asia Dry Eye Society. Unfortunately, India is not a part of Asia Dry Eye Society. I do not know why, but hopefully we would get a place in the subsequent meetings. So what does this society define dry eye as? It basically tells that it's a multifactorial disease, which we all know, which is common even in the TFOS DUS2 guidelines, but it plays an emphasis on the instability of the tear film. So in that sense, it's a very simple definition where you're looking only at unstable tear film and then correlating that with the patient symptoms, visual impairment, and sometimes it might be associated with ocular surface damage. So when you compare the DUS2 guidelines in terms of definition and the Asia Dry Eye Society, the difference is the DUS2 is more comprehensive. So it talks about tear film instability, but it talks about the pathophysiology in terms of hyperosmolarity and the ocular surface inflammation and neurosensory abnormalities playing etiological roles in the disease process. The Asia Dry Eye Society is more clinical in a sense. It just talks about an unstable tear film, and it tells you how you sync this unstable tear film with visual impairment and with your ocular surface staining. So when you look at the ADAs, it's basically patient symptoms in terms of a questionnaire along with a decreased tear film breakup time, which they qualify as less than 5 seconds. And when you have both, you will diagnose the patient as having dry eye disease. So in that sense, it's a very, very simple to perform algorithm where you have a questionnaire and a tear film breakup and you get your assessment of dry eye. But the most important thing is, for this, you have to use fluorescein in all your patients and have a look at how the tear film behaves. So you have two factors which affect the tear film. One would be the static factors, which are basically the mucin, the aqueous, and the lipid, which is there in the tears themselves. And you have the dynamic factors, which is basically related to the blink, either an incomplete blink or a blepharospasm or a lag of thalamus or a presence of a conjunctivochlesis, which can all alter the distribution of the tear film on the ocular surface. And imbalance between both will lead to an unstable tear film. Why are we so worried about an unstable tear film? Is basically because they proposed a concept, a terminology called as short tear film breakup time, which they said is because of decreased wettability of the surface, where there is absolutely no staining on the ocular surface. The tear film height is reasonably okay, but the patients complain severely of ocular fatigue, primarily seen in younger individuals and patients who use computer screens for a long period of time. And this does affect the visual dysfunction. And as you can see in this photo here, you have these global, you have these black dots, which are seen almost instantaneously as the tear film goes up. indicating that the tear is not able to surface the ocular surface epithelium in a proper manner. I'll come to the videos later. So when you compare both definitions, the deuce to diagnosis dry eye with a breakup time of less than 10 seconds, with the use of osmolarity, which is more than 308 milliosmoles, and the presence of ocular surface damage. Whereas the Asia dry eye looks at a tear film breakup of less than 5 seconds, primarily to look at the short breakup time. The advantage is we do not need any expensive gadgets to look at the osmolarity or any expensive gadgets to look at the meibography. You can just give an idea based on the tear film breakup pattern. So looking at the point of break, looking at the type of break is essential in making your diagnosis. So this, just remember these images because these are going to be very important when you look at diagnosing a patient with dry eye. The first one is called as an area break, where you have a lot of staining on the surface. The next one below is line break, where you have few streaks of lines. The third one is the spot break, which is what they call as the severe short breakup time dry eye. And sometimes when you have an early short breakup time dry eye, you can have something called as a dimple pattern, which basically is a horizontal wavy line in the center of your cornea. And what we look at evaporative dry eye would be a break in the tear film once the tear film is formed. So a random break is after your tear film movement stops, you give some time and then you start looking at where the random spots of breakup happens. And this is going to be more suggestive of an evaporative disease. So the advantage of the breakup pattern is it helps us identify the type of dry eye. So if you're looking at this kind of a staining pattern, and you will probably not see a movement of the fluorescein as the lid moves up, indicating the aqueous component is so low that there's hardly any tear resurfacing of the surface, which is indicative of a severe aqueous tear deficiency. When the aqueous tear deficiency is not so much, you will see a mild movement of the aqueous film, but you will see these linear streaks, which are called as line breaks, indicating that the thinnest point of the tear film breaks up as linear streaks, and that indicates an aqueous tear deficiency. The spot break and the dimple break basically deal with tear resurfacing issues, and they are primarily related to a mucin deficiency of the ocular surface, either the mucin on the surface epithelium or the soluble mucins on the aqueous space. And the last, in terms of a random break, is once your blink is over, the movement of the tear film stops, and then you give a couple of seconds and you will start seeing these dots as random breakup spots all over the surface, indicating an evaporative breakup. So based on this pattern, you can classify dry eye in a much more simpler manner. Again, when you're looking at an area break, you see this pattern almost right after the blink. Whereas a line break, the break will be seen as the fluorescein moves up. The spot break, this kind of a dot will be seen almost right after it, but a dimple break will be seen as the fluorescein moves up. The random break or the evaporative dryness is going to be after the fluorescein stops. That is, after your tear film is formed, then only it is going to get evaporated. So if you're going to comment on a lipid deficiency, you have to allow the tear film to form first and then look at a breakup of a random type. So this is some of the videos which I would thank Santen for providing me with from the Asia Dry Eye Society website. So this shows up an area breakup where you can see there is hardly any movement of the tear film when the lid moves up. You're seeing a diffuse staining. You can see the tear meniscus height is very low. In fact, even without looking at the movement of the tear film, you can look at this image and say this is a severe aqueous tear deficiency and you need to treat it. This is a line break where you can say once the tear film moves up, you can see linear streaks forming up, indicating an aqueous tear deficiency. It's less severe as compared to the previous video that we saw. So this is also suggestive of an aqueous tear deficiency. Here, if you compare the tear meniscus height, it is much better than what we had seen in the previous video. This is for mucin deficiency along with a bit of an aqueous tear deficiency, where once the patient blinks, you start seeing patterns of lines like a linear break, and then they coalesce to form some kind of a line, almost a horizontal line close to the center, like a dimple pattern. So this indicates decrease in the soluble mucin in the ocular surface, which causes a breakup of this. So again, this breakup happens as the tear is moving up, indicating a short breakup dry eye. or a decreased wettability as a cause for the tear film instability. This is a more severe form of mucin deficiency, where you can see these. So as soon as the lid moves up, you will see these blobs which are not staining. So it's not that it happens in all blinks, but when you keep looking at a couple of blinks, you will see this. So basically this tells you that the soluble mucins are not as much as it should be. So it's not able to coat the surface uniformly. Unlike where you have a mucin deficiency on the surface, you will always keep getting the spot break exactly in the same area. Say like what happens if the surface is keratinized, like in an SJS, or there is a bump on the epithelium, you will always keep getting that area break up faster or immediately as soon as the lid moves up. And this is suggestive of evaporative breakup, where once the lid forms, you're waiting, and then you start seeing these random spots of tear film breakup happening, indicating the tear film is formed, then it's exposed to the external surface and it starts breaking up. Again, the definition here for dry eye is a breakup less than 5 seconds, unlike the conventional TFOS guidelines, which is 10 seconds. So these were videos which were shared by Santen, going through some of the videos that we had taken at SN. So this is a patient with a severe breakup. You can see again, there's hardly any movement. I can see a bit of tear meniscus here, but when the patient blinks, there's hardly any movement of your tear film which is seen, indicating a severe area type of breakup. This is a less severe area breakup, where you can see a very minimal movement of the fluorescein as the lid goes up. You can see line breaks, and then since there's a large area where there is a breakup of the tear film, it would classify as an area breakup. This is a mucin deficiency, where you can see as soon as the blink happens, you are seeing these spots which are not getting coated with the tear film, indicating decreased or poor wettability of the ocular surface. This is a milder version of decreased wettability, where you have a linear break and then it coalesces to form this dimple pattern, which is exactly almost at the center of your cornea, indicating again a combination of both an aqueous tear deficiency along with decreased mucin on the ocular surface. This is, like I said, if there is a break which always happens exactly in the same area, it has something to do with the epithelium itself. So the epithelium is irregular, so you will always get a break. Again, it's decreased wettability, but it is more because of local epithelial irregularities. And this would be a Stevens-Johnson syndrome, where you have a keratinized surface and you know the tears cannot coat the surface. It's a poorly wetting surface, so the tears just runs off the ocular surface. And this would be a classical meibomian gland dysfunction, where you have the tear moving up, the tear is stable, and then you start seeing these spots come up here, here, multiple areas. You have random spots of tear breakup, which happen somewhere around the 5th to 6th second as such, indicating a mild to moderate meibomian gland dysfunction as such. And again, how the other factors play a role. Like in this video, you can see the blink is so grossly incomplete. It hardly moves about a millimeter down. So obviously there is tear deficiency, and if the blink is incomplete, it hampers the tear film surface more. So when you're looking at this tear film breakup pattern, why is it important? Is basically it also gives us an idea as to how you would want to treat it. And what the Asia Dry Eye Society has said is, when it is a severe ATD, you would probably look at retention of the fluid on the surface. When it's mild to moderate ATD, you would look at supplementation of fluid. For decreased wettability, you would be looking at supplementation of mucin. And for evaporative dry eye, you would be looking at supplementation of lipid, or if you don't have lipid, supplement fluid or mucin to try to at least improve the stability of the ocular surface tear film. So as far as the products which are available in Japan is concerned, for the severe breakup, they can go ahead with the punctal plugs or the preservative-free artificial tears. Diclofosol is a product which is available only in Japan and Korea and some of the other Asian countries, and that seems to work very well in mild to moderate disease, along with sodium hyaluronate, which seems to improve the aqueous tear deficiency. When it is a decreased mucin related thing, diclofosol seems to improve the mucin status also, because it has a role on the conjunctival cells, goblet cells. And when it is a random break or an evaporative dry eye, you would be looking again at sodium hyaluronate or diclofenac. So primarily, as far as diclofenac is concerned, in Japan, it works across all the three streams of the disease. So for them, it's quite simple, because whether it is aqueous tear deficiency, whether it is mucin deficiency, whether it is evaporative dry eye, they could probably give diclofenac for all patients. Whereas the other option would be, when you have a mucin deficiency, would be to use rebepamide, which has mucomimetic properties. Unfortunately, diclofenac is not available in India, and rebepamide, like the concentration which is available in Japan, is not available in India. So from an Indian scenario, what are we looking at? If you have a severe dry eye, you're probably looking at punctal cautery or plugs or preservative-free tears, either in form of gels or ointments. When you have a mild to moderate, any of the tear supplements could work, whether it is sodium hyaluronate, whether it's PEG PG, whether it's CMC or HPMC. When it is a spot break or a mucin deficiency, probably a PEG PG or a HPGuar, which has a mucomimetic effect, or a sodium hyaluronate would be better than a CMC or an HPMC based molecule. If you are looking at an evaporative dry eye, we do not have any lipid containing solution. We could probably think of using cyclosporine because it has an oil base, but the most commonly used ones would either be a sodium hyaluronate or a PEG PG to improve the retention of the tears on the surface and improve the tear breakup time. So this is in a nutshell what was given by the TFOD guidelines in terms of if it's lipid layer abnormality, warm compresses, and diclofenac. If it's an aqueous tear deficiency, artificial tears, any artificial tears could be used along with diclofenac or plugs based on the severity. If it's a mucin deficiency, you're looking at diclofenac or rebepamide, both of which are not available as far as an Indian scenario is concerned. If it's anything with the epithelium, again, a rebepamide or diclofenac, or you could use autoserum tears. And if there is ocular surface inflammation, we would probably need to use topical steroids for a short course of time or supplement cyclosporine. They do advocate even rebepamide in this group. However, again, like I said, our experience with rebepamide for the short time that we used fine tears, which was available, has not been very encouraging as such. So the difficulties with this way of diagnosing is the ATD. It's very simple to confirm the breakup pattern. We can look at the staining, you can look at the tear meniscus height, and you see the pattern. It's straightforward. The spot and the random breaks are sometimes difficult to appreciate even for us after seeing so many patients. We do not have the mucomimetic or the lipid replacements at present. So even if we diagnose the condition, we cannot effectively treat it. Diclofenac, like I said, is not available in India. We are waiting for it to be launched. But the advantage is it helps us understand the tear dynamics better. And the most important thing is a fairly inexpensive way of diagnosing and categorizing dry eye without having to look at investing in high-end gadgets to try to diagnose the disease. And it's a tool which is available for all ophthalmologists. Thank you.
Thank you, Dr. Bhaskar. And it was a nice overview on the Asia Dry Eye Society recommendations. Basically, the ADES recommendation is based on the unstable tear film, stability of the tear film, and like Dew's recommendation is more on, it deals more on hyperosmolarity and the surface inflammation and neuropathic pain, etc. I think as far as clinician is concerned, a clinician will find it easier to work on the ADES because you just put a fluorescein and get a pattern, and based on that, once you start understanding that pattern, you can think of what to give. I mean, maybe with time we will have all those drops which can be used as a component therapy for the dry eye disease. Any comment on the talk and
yeah, Rajesh, one thing which I found in Japan, first of all, it's this whole staining thing. It will take some getting used to in our mindset because we go straight into ocular surface analyzers and big machines. But this simple staining, all you need to get the excellent pictures that Bhaskar showed is a cobalt filter, which can be attached to our slip lamp or held separately as well. And then you get these sexy pictures which Bhaskar showed. Even without that, you get the pictures, they don't look as sexy. But in Japan, do you know the drops which are used frequently when you talked about preservative-free tears is simple saline. So they have drops which contain only saline, and somehow we have never used only saline in India because we have always gone to the pharma companies and they've given us drops which are becoming increasingly more expensive. But when I was there in Japan and I checked with them, the drop which is used across the board, just like we would use CMC perhaps in India for every dry eye, they use saline.
So I just
I
wanted
think,
to.
Rajesh, Bhaskar, you've done a wonderful, excellent presentation on a Asia Society, Dry Eye Society thing. And it is first time, I think, based on a fluorescein pattern diagnosis, your recommendation for a particular type of treatment for these group of patients. But unfortunately, we know that most dry eye patients will have a combination of all these things. So you can't isolate one particular area and you pinpoint that and they start treatment. I think further to this, I think they should come out with the group of patient as per their diagnosis, treatment, then the outcome. If the outcome support, because this type of diagnosis is a subjective diagnosis, so this has to be supported by the treatment outcome. Then you can say, okay, I was right for a diagnosis and my treatment was specifically for that and it got corrected. So that will comprehend the entire their classification subsequently.
If I could just
Yeah.
add, yeah. So there were two things. In fact, even when we were initially discussing with the Japanese people when they had come down to Caracon and stuff like that, was the fact that we need to emphasize to ophthalmologists the importance of using fluorescein to look at the tear film and the eye, when instead of just labeling anybody who comes with an irritation as having dry eye and prescribing CMC even without doing the basic investigation, which does seem to happen. And the problem, like you said, yes, even for us, it's been almost a year and a half, and I've been trying to look at the tear film to try to see if I can understand what they say by the different patterns. And it does take a lot of time for us to realize what it is. It's a lot easier to actually record the video and then see the video for you to understand rather than actually seeing it on the patient, because then it moves so fast. Sometimes your brain doesn't comprehend what you are seeing. Having said that, even for the osmolarity and all the investigational tools, everything seems to be, you have a group which believes in osmolarity, which believes in inflammation, which believes in going in a particular direction. This is another group which believes in going in the other direction. We have to somehow take what is best for us from both and try to reach a stage where we can merge objective data with subjective evaluation that we do and see how best we can manage our patients.
That's true, Bhaskar. People today present here, speakers, panelists, we all agree the beauty or a tear film assessment is the best possible diagnostic tool for any ocular surface disorder. Let it be dry eye as such. You correctly said this has to be emphasized. We all do, but it has to be emphasized to all general practitioners. Every patient with irritation or a watering should be put a fluorescein. It is a compulsory, it's a mandatory part of examination should be there for every group of people. Let it be a retina person or any person, they should always put one drop fluorescein, and that's so the entire ocular surface world that people miss it. Like I get fascinated seeing the fluorescein angiography, other things, those people show us, but we have never shown them the videos you have shown. So these videos should be a part of routine presentation everywhere. The general practitioner should understand fluorescein is a very important examination tool for an ocular surface. If they understand this, half of the dry eye management will be simple.
Yes, definitely.
May I make a comment here? I think it's extremely important and to overemphasize the importance of fluorescent staining. And I think in spite of everything that we've been doing over the last 25, 30 years, that is the one single test that still has not been replaced or bettered, actually, as compared to what we have seen. But the important thing that I have realized over these so many years is the variation that I get. And the problem with the variation is the way we do our fluorescent staining. There is no standard. There is no standard in the fluorescent strip. There is no standard in what you wet it with. If it's a moderately severe dry eye, it won't take stain. If you lose too little stain, you can actually alter it. I can change the fluorescent pattern of a patient depending on how I do the staining. So then where is the how can you do away with that subjectivity? So I think as a group, we need to figure out what would be the best way to do the fluorescent stain, which is consistent. And unless we are able to do that, we're going to get these overlaps and these confusions. So I don't know what Dr. Tyal has to say about that, but that's something that I find is a big problem. If I use a wetting agent, then it changes the picture. If I don't use a wetting agent, there's not enough fluorescent to make a diagnosis. So that is something that is a big problem, and I've not been able to figure out the best way to go about it.
During one of the studies, we did get fluorescein in ampules like the Chlorocol apps, and you could cut it and do it. But the problem with that is that increases the cost of fluorescein significantly, and then some company has to be ready to do that. And again, the possibility of contamination of a liquid fluorescein is with Pseudomonas is much higher. So then you don't want to be putting a Pseudomonas in a dry eye patient and burning your fingers. So that's definitely an issue. What they do say is you put 2 drops / one drop off, and then you do it, is what has been recommended in the TFOD diagnosis thing. But again, if your eyes are very dry, that much amount will not take up any stain. You will not see anything. And like you said, if you put more, it will change the pattern completely.
Even different manufacturers have, some fluorescent just doesn't release. Some only it looks pretty, but it actually doesn't get into the eye. And so I really don't know how to, this is a bit of a conundrum which I haven't yet been able to figure out.
I think there are so many factors, like Sir said, so many factors, and tear film is just an end result of, what you see as a result of myriad of factors which are involved in the ocular surface, which could be the meibomian gland, which could be your, goblet cells. And this is just the end result, which you see. So I think just on the basis of end result, it is not good to optimize your treatment, because the ocular surface is, at least ocular surface world has far more reaching effects, as compared to only the tear film. So that alone cannot be taken as a method to objectivize your treatment.
I think, ma'am, he is very nicely classified clinically. I mean, the society is classified clinically. This cannot be taken as a complete workup of that. I mean, people who are not accessible to other things, they can just be more vigilant on
For
their.
the general practitioners, I think it is a good classification, but not for, cornea specialists will have to look beyond this to diagnose and treat.
Ma'am, just a comment, like, Dr. Bhaskar, like, you showed those excellent videos, like, do you use a normal saline to wet it, and then where do you touch it? I mean, nowadays, what I do is maybe touch it just inside the lid margin. It disturbs the tears the least. Some people, they put it on a superior temporal area, which is not a good idea. I think, or the lower fornix, again, it irritates, can cause reflex tearing. What is your guide? Do you wipe the excess of the fluorescent? Because so much is depending on the fluorescent serum which you have shown us.
So we were using, in fact, Paracane earlier till the Keracon webinar, where there was a lot of discussion on what is the agent that should be used. And then we shifted to normal saline as such. And we put 2 drops on the fluorescein, kind of shake it off so the excess drop falls, and just touch it at the lid margin. And we see. Sometimes we still might end up getting a little bit more of fluorescein, in which case we just ask them to close the eye, gently dab it, and then reassess the surface as such.
Okay. So if there is any other comment.
I want to observe that there are, in external eye examination, there are 2 critical things. One is your residence time with the patient on the slit lamp. And then when you see these patterns, that will take your, let us say, the observation time and your assessment time. Ever since the pandemic, my time with the slit lamp examination is reduced by 50%, or if not more. So either I race my mind, and if I wish I had a race of mind like Rishi and Titial together to give me a very fast analysis, it doesn't happen. And the time taken to see all those patterns and so many other findings which are lying there on the eyeball, and the cornea and the superior part of the globe, everything is important to so-called put your head into the analysis of the patient's complaint. So now we are left with a shorter time on slit lamp, and we have to work very fast or race our minds to go to some kind of conclusion. So times are changing. And fortunately, as Rishi is saying, we have a lot more automated examination modules to help us raise that part of patient examination. But there is no substitute for examining the patient on slit lamp. At least that is the only place where you pick up your finding most. Thank you.
I think Bhaskar had suggested, if you can record your this particular examination, you can see your video panel and reassess them, because sometimes very fast. You hardly appreciate.
Work fast.
Happens very quick.
Yeah.
Maybe you can see
We have
repeatedly and then...
Dr. JK Reddy sir. You are so innovative. Can you suggest something?
It's a high-speed camera, sir. The regular frame rate, which you use for 30-60, if you just like a mobile's now 120 frames, then you slow it a little bit, then you can see it very nicely. But it needs an entirely new setup and where to do it. The video recording, as you said, is the best one as far as the floors.
Also, we have to
people now,
the poor fellow who has to clean up after you've done 50 strips of fluorescent and you have to clean up that area of the slit lamp. Think about that chap also. It's not easy to flip the thing. You produce a lot of staining on your clothes and in the surrounding areas.
Room will get yellow.
Yeah, totally. It's a disaster.
That's a surface disorder of the cloth, I guess. So we move on to the next.
In a pandemic, all these, touching and flipping the lids are given to less than 50-year people. We just see the videos, Okay, Rajesh,
So,
sorry.
We move on to the next speaker, and that is Dr. Quresh Maskati, who will be talking with us about corneal regeneration in dry eye management, how it is important.
Thank you, Rajesh. And if I'm visible, I'll start away.
Yes, sir.
Okay, so corneal regeneration in dry eye management. I'm grateful to Centen and to all of you, ISCRIS, for inviting me. Centen for sharing some of their slides with me. So after having done a broad overview with Rishi and looked at how staining was made so simple by Bhaskar, let's talk a little bit more technical about what exactly goes on as far as the cornea surface is concerned in normal patients and in dry eye patients. And why is it so important that we learn this? So there are a huge number of risk factors of dry eye and ocular surface disease. I've just tried to make this is a busy slide, but see the things which are put in blue, like lid viper epitheliopathy, SLK, short breakup time, eye strain, video terminals, contact lenses. This is where the staining score is less. There is less staining. And some of the other things like severe neuropathic keratopathy, lag ophthalmos, Steven-Johnson, drug toxicity, graft versus host, which is in yellow, is where you get more of a staining score. And all these things contribute towards tear stability decreasing, like the Asia Dry Eye Society's classification, and cause keratoconjunctival epithelial disorders. So this is the pink arrows is what causes the stability to decrease, and in turn the blue arrows show where it causes this epithelial disorders. And the epithelial disorders are the erosions, the ulcers, the filamentary keratitis, and so on. So that's a small classification of this busy slide. Let's go to make a little more complex structure simple. We know the corneal structure is the epithelium and the stroma, the decimates, what we were taught, the ABCDE of the cornea: anterior epithelium, Bowman's membrane, corneal stroma. D was decimates and E was endothelium, till this gentleman Harbinder Dua came and confused us with one more layer. But we are not talking about that. We are talking only about the multiple layers, which is the epithelium and its own basal membrane of the epithelium, and then the Bowman's membrane, which is a condensation of the stroma just below the epithelium. So look at just only this picture. Now here you have the epithelium is normally has got tight junctions, desmosomes and hemidesmosomes, which are tightly bound so that it protects, in normal circumstances, it protects you against the penetration of chemicals from outside, aqueous humor from inside. So these are tight junctions. And we know that our cornea has got abundant nerve supply. What it lacks in blood supply, it makes up with nerve supply. And if there is any injury to the cornea, this corneal nerve supply, these plexus that you're seeing on the right side are damaged, and it takes a long time for these to regenerate. How do we know this? Because for years and years we've been doing penetrating keratoplasty, and we know that the new cornea takes 6 months or more to get some semblance of nerve supply back into the donor cornea which we have, and it never really catches up with what is normal. So we know that this is important, the amount of damage that we get to the corneal nerves. Accordingly, now we classify corneal epithelial disorders into mild disorders where there's SPKs, superficial punctate keratopathy, where the superficial cells and sometimes the wing layers, as you can see in the graphic, are damaged, but the basal layers are intact. And then if you go to corneal erosions, which is a little more moderate, all the layers of the cornea are damaged, but the stroma, the basement membrane, the Bowman's membrane, the stroma are all intact. And then infection comes in, and you can get something which is called corneal ulcer, where it penetrates not only the epithelium, but the stroma is also affected because the Bowman's membrane is damaged. And if there is an inside-out injury, the corneal edema which occurs, those tight junctions are destroyed, then water from the aqueous goes through the stroma and balloons up the cornea, causing corneal edema. It could be vice versa also. You could get the water from outside coming in and causing corneal edema as well. So these are some of the corneal epithelial disorders, and this is what we mean, so that we are all of us on the same page. Bhaskar talked to us about the simple test with fluorescein, which we can do, and it stains this tissue, and the severity of the SPKs can be used as a basis for treatment to decide how many times a day you should be putting the drops and other modalities. So let's go a little quickly over things that Bhaskar has already covered. The corneal epithelial disorder due to dry eye, you know the different patterns now. Also, we need to see which area of the cornea is the staining. Is it in the lower 1/3? Is it in the middle area, which is between the interpalpebral area? Is the lesion going all over the cornea? Because all these have their own interpretations. So if it is in the lower 1/3, which is normally where it begins the interface between the upper and lower lids, this is where you would get this dry eye coming initially, and then it could be further worsening with time. So there are different dyes that we use in the staining. Bhaskar talked about fluorescein, which is the commonest dye which we have. Rose Bengal was something that we would give our residents to do thesis topics on, because the patients would grumble and scream because it causes a lot of pain. So ideally, you should use some topical anesthesia in this. But the fluorescein stains the cell deficient site. Rose Bengal will stain all the cells which don't have sufficient mucin on them. Lissamine green is a first cousin of Rose Bengal from its mother's side. So it does exactly what Rose Bengal does, but at the same time is more friendly to the eye. It's not painful. And so if you like your residents, then instead of giving them Rose Bengal, you could use Lissamine green. You get strips of all these three available, fortunately, in our country. So you could carry out comparative studies, and you can see the type of cells which are stained with these various stains. So Rose Bengal, again to reiterate, stains keratoconjunctival epithelial cells which are not covered with mucin. So it's primarily used to detect conjunctival epithelial disorders. Rose Bengal is excellent for carcinomas in situ when you want to stain these. So these are stains areas where the mucin is deficient. So conjunctiva more than cornea. Cornea takes a long time. It takes more than 1 minute to 2 minutes for the cornea to stain, a little less time for the conjunctiva, but they both take a long time with Rose Bengal and Lissamine green as compared to fluorescein, which is almost instant coffee staining. So you could use topical anesthesia. Lissamine green stains also the same, degenerative and dead cells, as well as cell deficient sites and low levels of cytotoxicity and irritation. And the yield is the same as with Rose Bengal. Again, this is the different types of staining patterns. We won't go into these. Again, just to point out the upper, middle, and the lower part, which is what we also need to see. So if you see primarily the upper area, this is classical superior limbic keratoconjunctivitis or SLK. Even in an allergy, especially the spring catarrh, where you get the palpebral conjunctiva involved, you'll get the upper area because of the palpebral, the papillae on the palpebral conjunctiva. The upper area will be more involved in this. And if there are concretions in the palpebral conjunctiva, again, the upper area will be more staining. So if you get preferentially upper staining, these are some of the causes. If you get in the eyelid aperture, in the mid zone, as it were, almost every dry eye will stain here. neuroparalytic keratopathy because you get 3 and 9 o'clock corneal nerves entering. So if you have neuroparalytic, this is the preferential area where it will get. Again, diabetic keratopathy because it's related to the nerves. This is where you'll get the staining. And if it's more in the lower part, you would first think in terms of meibomian gland dysfunction, blepharitis, both the seborrheic as well as the all types of blepharitis would give you the lower part involved. And if there is any insufficient closure, conjunctivochalasis, these are where you get the lower part involved. So aside from what Bhaskar taught us about the patterns, just where the staining occurs also is sometimes helpful, not mutually exclusive. Let's go on to the breakup time, which is again something with the Asian Dry Eye Society has talked so much about. You have two types of breakup time, the invasive and the non-invasive breakup time. And when they did, you could, we have machines which measure the breakup time, which is non-invasive, but you could use the breakup time with the fluorescein as well. And they found that when they did a small study of 12 patients with a short breakup time, they found that use of HA, whether they use 0.1 or they use 0.3, it did have a significant improvement in the breakup time with HA being used. Now let's look at the healing mechanism of corneal epithelium. Fibronectin is something that I want to introduce here. Fibronectin is an important constituent which promotes healthy epithelial healing. So fibronectin, what is fibronectin? It is expressed in cell deficient sites. So wherever the cells are deficient, imagine a corneal abrasion and that area is got deficient of cells. So you can see on this in the first slide, those cells which are bunched up over there, and there is one area where there is deficiency. So wherever there is deficiency, the fibronectin is produced. Now when fibronectin, which is shown as FN over here, what does fibronectin do? Fibronectin, it teases the cells which are standing on in an ivory tower on the side saying, "Tum log udhar kya khade ho? Come and slide over me." So it asks the cells to extend in a horizontal direction on the fibronectin network. These extended cells, once they come over the fibronectin, they feel khush. And then they start proliferating and differentiating as we have always been taught from the basal columnar cells to the sphenoidal, the wing-like cells, and then the terminal cells. So the fibronectin is very important in promoting this wound healing to occur, and in exciting or in promoting the good guys, the normal cells, to slide over the fibronectin and differentiate. What does HA do over here? You can have a spontaneous recovery. Look at the lower part of the slide first. So you can have a spontaneous recovery with fibronectin itself alone, but it takes a longer time. The cells slowly extend on fibronectin and cause a spontaneous cure. But if you got HA over there at that time, then the combination of sodium hyaluronate along with fibronectin increases the cell adhesion, and cells tend to extend earlier, and a spontaneous recovery alone with only fibronectin, while if you see the top of the slide, HA with fibronectin, you see all the cells dying to tumble over each other and come and occupy the empty space which was there for the abrasion. So the combination is much better and works as a synergistically to cause healing or regeneration much faster. So they did an experiment on rabbits, and they found that if you see the base group, which is the gray line that you can see, and the hours after detachment, you see that how long it took for the cells to come into place. And you see the blue line, which is the sodium HA group, and you find that the same effect of decrease of injury area occurs. Now, they did this whether you removed the basement membrane or you kept it intact. So you know that the lowest line below the epithelium, before the Bowman membrane, is the epithelial basement membrane. So they did a very interesting study. Whether the basement membrane was removed or it was kept intact, they found the results were exactly the same. So after 24 hours, the injury site decreased significantly. And if the blue line, which shows the sodium HA group, it decrease of the surface area left behind, or the increase or the less surface area which was left uncovered, significantly more in the HA group as compared to only the baseline group. So it therefore said that the healing promoting effects of sodium HA is it facilitates the adhesion and then expansion. So when the cells come as an adhesion. It's like you're putting Fevicol over there. So the cells come over there and they get attracted. And once they come there, they start expanding over there. So you see the picture which you see on the left, which is the before treatment with HA. And you see that they've shown the area which is covered. And if you put the HA over there, see the larger area which is shown in the arrow, the double-ended arrow picture, which is a after treatment with HA, which shows that there is better epithelial healing with HA as without this. So that's a very nice way of showing this is an actual picture, the patient picture, which is shown to you. And also they found that it's independent of the molecular weight. So what is important when you're purchasing an HA drop, because we have about 20-30 pharma companies making HA. So some of them tell you that ours has got a higher molecular weight or a lower molecular weight. They found that the corneal wound healing is independent of the molecular weight, but it does depend on the concentration of HA. Is it 0.1%, 0.18%? That matters, not the molecular weight. So that's again an important finding that we find. We know that one of the other effects that HA has is the water retention effects. So water retention is a huge, out of all the lubricant drops that we have, the amount of water that a drug can retain is maximum with HA. And why is it so? This slide, even I don't pretend to understand. Santen loaned it to me, sort of politeness. Japanese are polite, we need to be polite. So I showed this slide to you. And I also looked at it for 5 minutes to try and make some sense of this slide. But if we all agree that we don't really understand it, let's move on to a slide that I created, which is more easy to understand. See, what HA is like, if you imagine an electrical wire, a red electrical wire, which, plastic coated, and you coil that wire up. So the HA in the eye acts like that coiled electrical wire. Every time your lid opens and closes, that wire unravels and closes. So because of the shearing effect. And HA has this, so therefore the HA remains in the eye, and it's so cooling to the eye because of the shearing effect. The HA never goes away from the surface. Another quality that HA has is this water bridge, which is formed between some of the groups which are there. We are not chemistry students, so we won't talk about which group and which group. You don't have to remember that. But it traps the molecule by a chemical reaction. That means the water is trapped between some groups of carboxyl and other ions, and that's a water bridge which is formed. But by being physical, again, if you imagine that electrical wire which is coiled up, now within this coiling, it holds water. How much water? 1,000 times its weight in water. So we put 1 gram of HA in the eye, 1,000 grams or 1 kilo of water it could trap in the eye. So that is an amazing quality. Not that we are putting 1 gram of HA and not that we are trapping a kilo of water in the eye. But just to give you an example, that by two ways, physical means as well as by chemical means, HA has this unique ability to trap its more than its weight in water. Something like the ant, which can carry many times its weight of food to its shelter. So effects of keratoconjunctivitis, epithelium disorder associated with dry eye, you see that HA decreases. Again, if you don't go through the entire slide, just read what I have put in yellow there. HA decreases the staining pattern and it decreases the foreign body sensation compared to controls. And again, if you just look at the yellow parts of the slide, which I have created, the sodium HA group significantly therefore improved keratoconjunctival epithelial disorder associated with wearing contact lenses. Dr. Tithial talked about contact lenses. So versus the placebo group. So even in contact lens, it is safe to use HA. It doesn't spoil the contact lens. It's not that HA is a magic drug. Subjectively, the patients didn't feel much difference whether you used a placebo or the HA. But objectively, the slit lamp findings and the staining scores were better compared to the placebo group. So the patient might not feel a hell of a lot of difference, but you know that it is working in these patients. So let's go. What is the take-home message? Take-home message is that hydration, as I told you 1,000 times its weight, along with the corneal epithelial healing because of its effect on the fibronectin synergistic effect, these two combine to give a unique ability to HA to provide symptomatic relief to dry eye patients. I thank you for your attention. I tried not to overload you. So just two take-home messages if you can get then the jigsaw puzzle of dry eye we will be closer to completing. Thank you so much.
Thank you, sir, for an excellent presentation and very lively presentation. And you told us very nicely what are the factors and how this regeneration of various components of the cornea works and what helps in expediting its regeneration. Any comment from any of the panelists and any of the panelists? Any comment?
I think it was a very theoretical subject which Dr. Muscati, by the virtue of the humor that he possesses and by the way he presents, he made it so lively. Otherwise, it is a very basic kind of a presentation, with all the facts about hyaluronic acid.
So there's a couple of questions from people who are listening to us. There's one question from Dr. Surabhi Dutt, and she wants to know about the preservatives like perborate and polyquad is said to be constituents of preservative-free drops. So are we actually using preservative-free drops? So what she means by saying that if they're perborate or polyquad, are these drops preservative-free or not exactly preservative-free, in the bracket of disintegratable preservatives, something like that?
You see, it really depends on which pharma rep has visited you last, because the guy who's promoting drugs which are polyquad tells you that it's very epithelium friendly, until the other guy who comes in and says that, my drops have got perborate and it is much better. That one is a quaternary ammonium compound and there is a mild toxic effect because of detergent and whatever. And just when you're believing that, then the CMC guys come in and tell you that ours is a proprietary thing. That's why we use teal green bottles to preserve it, and it just breaks up into inactive components like water and light and water and whatever with light. Then when you hear that, then somebody says, no, but then the light which they're talking about, is it sunlight or artificial light? It doesn't break up. So it really depends on what I find is that ideal would be totally preservative free, which you can get a single dose if we can use those. And these are not very expensive now. The prices have come down. Roughly, it's about 10 rupees for a day's supply. I ask the patients to cap it again. And if they're usually, especially housewives and others who are at home, they can preserve it easily in a small bowl, a metal bowl in the fridge, so that it doesn't spill over and doesn't get contaminated. So 10 rupees for a day's supply of that's genuine preservative free would be ideal. After that would be the drugs with all the disappearing preservatives that would go as the second line. So if you have to use drops for more than 4 times a day and you can't use those single dose, then I would go for that with no choice. And then would be the drugs with the benzalkonium chloride and the other ones which we know are toxic. Even those are not so bad now, because for the dry eye products, they've reduced the quantity of benzalkonium chloride considerably over the last 10 years that I've been seeing. So they're also not so toxic. So let's look at more at the active ingredients and not worry too much about the preservatives is what my take-home message would be.
I think the one of the things, Rajesh, would be the frequency with which we would use these drops. And I think even though Quresh is absolutely right that the concentration of BAK has dropped to as low as 0.004 and 0.002, which is much less than what it used to be. And these so-called transiently preserved drops are a fair misnomer. I don't know how transient that preservation is. So I think I agree that the preservative-free, absolutely preservative-free, and the unit doses would be the best way forward. And I think we must also try and convince the industry that we will continue to use these products. They find it economically unviable to push these. And we have to sort of make an effort to ensure that we prescribe these more often, and that's why they're able to then at least bring it to the market, and the price will come down. Because it's a cycle. When it's used, the production costs go down, and so on. The wastage goes down, and they'll be able to produce more and more of these. In the West, there's so much more option available in preservative-free. And I was in Sri Lanka recently, and they had CMC preservative-free by Optiv. They were producing Optiv. There is available in Unims forms, whereas in India, it's only available in the bottled form. So I don't know why they don't introduce it here as well.
Okay.
They're also using Novella technology bottles. Those bottles are expensive. They cost about 105, 110 rupees just for the bottle. But they say that you can keep the zero preservative in those bottles. So they're using it for antibiotics as well as for some of the teardrops now.
And there's less risk of contamination as well in
Yes.
bottles. Yeah.
I have a question.
Yeah.
Thank you for the talk. Now, if we have the combinations of CMC with the HA and with the trapping ability of the HA, do you think that in some way that's a little bit more superior in, increasing the moisture in the eye?
Yes, yes. I am a great fan of the combination of HA with CMC. So first of all, they've done several experiments with CMC plus HA, and they found that they are synergistic. Plus, the CMC has got a mucomimetic effect. It does preserve goblet cells as well to some extent. So the combination is good.
Yeah, I think the TFOS report also, if I remember correctly, they said that it was more effective.
Okay, so we move on to the next speaker and the last speaker of the session, and that is Dr. J.K. Reddy, and he'll be talking to us about something which we keep doing very often, and that is biometry and cataract surgery. So let's listen to him on the topic of impact of ocular surface disorder on biometry.
You're not audible.
Dr. Reddy? No, you have to unmute yourself.
Unmute.
No, you're still mute. Admin, can you unmute Dr. Reddy?
He has to click on it.
Okay. Yeah.
Yeah, done.
Yeah.
Yeah, I'm visible, I think.
Yeah.
Yeah, thanks, Dr. Rajsingha, for invitation, and Dr. Namrata Sharma, Professor Namrata Sharma, for kind introduction. And coming to my last talk, the ocular biometry in ocular surface disorder. The biometry, initially, we have three components here: the cathometry, corneal power calculation, measurement, and axial length, and the formulas. They are just a data analysis. The formulas does. The first two are the data collection, and so far till 2 to 3 years back, it is axial length is the most variable parameter, and which is very difficult to measure very accurately. But this problem is solved with optical biometers. Once this problem is solved, then we had the other problem. Now the major problem we found is cathometry is a big problem, measuring the accurate cathometry reading. The once considered for a long time, it is a very insignificant factor in ocular biometry, but now it became the most significant factor and very sensitive to measurements. That's the main challenge here. And the true power is almost never measured so far with all the modern gadgets. The factors that influence the cathometry most commonest, I'm coming from the most commonest one is the ocular surface OSD. The measurements, because the measurements depends on the reflection from precorneal tear film. Once the tear film is compromised, even to a minor extent, the measurements you get and Dr. Bhaskar Srinivasan very nicely. So every time it's moving, it's changing so much. So when you take measurements, also same thing will be reflected in our data collection. The unhealthy ocular surface is a common cause of wrong data or a inter-observer variability high. So one of the commonest is the lids. To be look into that, one is the ptosis is one of the common one because the data points will be missing in the upper half of the lid. And the leg ophthalmos, ectopen, all the produces acquisition of data problem. So coming to the OSD dry eye and pterisium or corneal degenerations, of course, corneal opacities, this comes as a differential diagnosis of dry eye-like picture. Most commonest one is the dry eye and pterisium. Look at this, how we get in a simple one is a auto cathometry readings. You need a nice mice like this to get a data. But you look at it here in the pterisium case. So here also, it gives very nice reading, 42.5, 44 with again with the rule astigmatism of 1.5, and you get a very nice reading. But if you don't see what the data it has analyzed, then you are totally in a mess. You implant a toric IOL and you don't get a desired result, whereas you get a very nice reading from the autocatometer. Same time, see, this is a case of dry eye. There are no data at all. These Myers are all distorted, nothing, but it is able to analyze very nicely and give the result for 2.5, 44, and 175 degrees axis. So if you don't look at the data which it is acquired and use this data for calculating a biometry, we will be totally in a wrong place in implanting, in calculating the results. These optical devices, these devices which measure the corneal power and even topographers, they are very powerful in calculation. But it comes to the intelligence, they are almost like morons. They cannot differentiate a little bit a loss of data. Whatever you give it, they analyze the data and give a result. But they cannot judge whether there is a valuable or reasonably value of the data which they collected. This is a case of ptosis where there is no data at all in the upper points, but it measures. It measures and gives a reading. This is another example where the data points are missing, but still it measures. When it comes to the topographers, the plasto-based ones, this is a very nice picture we are supposed to get it. But even if you get a case of dry eye where you lost all the Myers irregular, but still when you put on analysis, it will analyze and give a data. And the data here, if you see it, it gives a cataract reading of 4 diopters, 2.6 diopters, and you put in a toric IOL based on this, and with a corneal power map like this, you are totally in wrong results. So this is another case where you have a sectoral dry eye due to incomplete blink and a partial lag of thalmus. And this is another case. This is the same type where there is a dry spots forming in the lower part, and but still the the machine analyzes the data. When it comes to the most modern, I mean, better equipment, so tomographers, you are still in trouble. At least in this, if you look at the raw data, you can say this is wrong. I don't want that. If you can access and keep the records, but here you can't even see that. So whatever you analyze here, they cannot say ocular surface data very predictably or even for observer to analyze it. So here still we are more in trouble with the tomographers than with topographers. So for example, this is a case of dry eye. You see the pattern, but nicely it gives 1.2 diopters of astigmatism in steep axis is 94 degrees. So you put a horizontally a toric lens and you don't get the expected results. And this is another case where you have a partial data loss. So, but still it analyzes and gives a 1.4 diopter of astigmatism. But if you look at physically, you have a here a 46 and here is a 42. This is we called as a hemimeridian corneal power difference. If it is a true power difference, even a toric IOL cannot correct this, and you will end up with a surprise, an unhappy patient, because all 4 meridians, here it is 42.5, here it is 42, here is 46.5, here is 44. Nowhere around the central cornea, the power is the same. So whatever IOL intraocular lens you put it, the patient lands up in problem. This case is better to select a EDOF lens, which gives reasonably good results. And this is a case of pterygium, where you get a analysis, topography, even cartometry becomes totally confusing. Here you look at the point, it's a 37.38, and opposite side is 41, and above is 44 and 43. But if you take the readings, it gives nicely 4.5 diopter of astigmatism. But if you put a 4.5 diopter astigmatism correcting toric IOL in this, the patient lands up with a undercorrection on the nasal side and overcorrection on the temporal side. And of course, superior is reasonably good data. So the ultimate result, patient have a ghosting of images, and he will be very unhappy with the result. And this one with the same thing shown in a magnified. You have a 4 diopter of astigmatism. You look here 35, and this side is the 40. So whatever intraocular lens, because our lenses are rotational symmetrical, you cannot correct on both sides with the same toric cylinder. One side it becomes under-corrected, the other side becomes over-corrected with a toric IOL placed in the vertical axis. And these are few more examples of milder forms we routinely see when you take a topography in the case of ocular surface disorder. And this is another example where you see a hemi-meridian problem. Here, the addition to the hemi-meridian problem of power axis also. If you look at the axis in this particular patient, it's not orthogonal. It's a skewed axis. You cannot place a toric IOLs in this skewed axis very accurately and promise a good. There may be some amount of benefit, but they don't get a full benefit of a normal toric lenses. And this is in a, same picture. For example, the axis is skewed almost by 40 degrees. So you don't get, when you put an IOL, you have to put either in this axis, or you have to put it in a average of this axis. So that won't correct properly, and patient lands up with a lot of coma and the ghosting of images. This is a few more examples of same type of problems we face in topography. The commonest cause of error in now we found in biometry is keratometry. Axial length problem is solved, and the formulas, of course, we cannot be. There are so many versions. Formula should work. It works in all optical devices except for the eye. Why not for the eye? It should work. So the problem is, I feel, is more the measurement of the corneal power. And in elderly patient, OSD is a very important case. Unless we prior treat them with a proper treatment, as spoken by my previous speakers, and then you get an accurate reading and you maintain the treatment, the visual quality will be very much compromised, and the premium IOLs are not going to give the satisfactory results as expected. Thank you very much for this opportunity.
Thank you, Dr. Reddy. It was a very nice presentation, and a presentation on something which we keep facing, in our day-to-day practice. Any comment, any question on?
So there is a question for Dr. Reddy. These are the things very nicely presented and showed what are the problems we routinely face in the cases of dry eye. But what are the quick things which you practically do to get away with the wrong error estimation of the errors? Because if it's a dry surface, fine. You are bound to get a wrong keratometry or a erroneous keratometry. What's the quick thing which you would like to do? Apart from everything, because
see, as rightly pointed out by previous speakers, especially Dr. Rishi and Dr. Jeevan, sir, the clinical assessment, even the few seconds we see in the slit lamp nowadays, with whatever reasons in a busy practice or a normal practice. So we mention in the case sheet, this is it's not a simple case. It is a ptosis or a pterygium, that one, or whatever may be. So those cases, we train our staff to look at the raw data, whether it's mites are round or mites are irregular, not look at the numbers, but look at the, that's a very simple thing. They easily learn because we don't see that. And it's very difficult to import that raw data into the EMR. It's not, still we didn't find it. It's possible, they're saying, but the values only will be imported. So that's useless. The values, they give very nice values. As I told you, all these machines are beautiful calculators, but intelligence-wise, they are below morons. So they cannot.
I think very truly said. But what I think is that immediately when you're doing that keratometry and all those, if in suspected cases of moderate dry eyes or something, if you instill sodium hyaluronate or a tear substitute and immediately do the keratometric reading, you are slightly close. But what the fallacy, what you achieve? That is what I want to.
We had to treat them. The sodium hyaluronate HA, as Dr. Kuresh has nicely explained, what we found in my practice is putting 6 to 8 times a day. It doesn't matter. You just apply 2 to 3 times. I found if they get benefit, they are comfortable, it's fine. If you increase 6, 10, 10, no, it doesn't work like that. So we prior treat them and at least 1 to 2 hours is my uh, deadline. So any drop put 2 hours taking before doing biometry, I don't take that as acceptable. Any drop, this is dry eye drops or antibiotics or dilatation. 2 hours before you take biometry, I should not be applied any eye drops.
Dr. Ajay, you have been, actively involved in, cornea as well as cataract procedures. Your comment on that? Anything you would like to add on?
Yeah, I recently came across one patient who was advised toric. And when you, again, I come back to the slit lamp most of the time. So when you look at those astigmatism, which were looking very fantastic, there was no pentacam done, of course. And this is where I find Dr. Reddy's talk very interesting. This patient had a full thickness perforation in the superior cornea. So that would give a completely non-orthogonal astigmatism. And whatever good lens you might put as a toric is never going to function there. So sometimes there are old injury scars lying in one of the paracentral areas. And these are the one which will always give you a non-orthogonal astigmatism. So when you carefully look them on the slit lamp and you find something which is not explaining your keratometry nicely, I think that is one point where you have to be very alert to offer a toric lens, which normally gives excellent results in the good astigmatic cases. But these are the cases which Dr. Reddy has beautifully highlighted. One has to clearly watch out for the promise of a toric lens technology to the patient before he realizes he's not going to achieve it. So I think watching these scars, watching the kind of astigmatism which is presenting on your different keratometry machines, they really kind of alert you to approach these cases differently.
I am in solo private practice, so I do everything myself with one assistant. So when I'm doing the biometry, I really can't afford to do what JK is saying, that no drops for 2 hours because I will lose my patient. So I have patient walking in, he is dilated for retina examination, his cataract is assessed, then he's told he's got cataract, and I tell him that we'll do your biometry today itself, just so that something is done, and then he gets investigated and comes back with the reports for which, after which I do surgery. So I can't really push him to another date because 2 hours before, I mean, it's 45 minutes before a drop has been put to dilate. I find that really it makes no difference. Yes, if it's a dry eye patient, then the Myers are distorted when I'm doing keratometry. I will do what Nilesh says, is that put a drop of the tears. I will retake it 3-4 times. I will take the readings of the keratometry. I have a manual keratometer, which I use. So I will take it 3-4 times. And then if they are near each other every time, then I will accept that or average it out. And I find that really I'm okay. I'm not, Ajay, to be honest, I don't do too much of premium IOL, so I think I escape with that.
Dr. Rajiv?
I think, most clinical practice now, people have, would do first thing they do a biometry of their patient.
Yes, that's what
before doing anything. That's become a trend nowadays. And especially those people who have acquired optical biometers, and which gives one of the best biometry possible nowadays. And JK nicely highlighted in the beginning, the axial length problems have been solved now. Correctly said, the keratometry or a corneal power is the major challenge to be incorporated into a newer generation formulas. But I think if we start with the biometry first, then do a subsequent examination, most things are solved. Then Kuresh, you can do dilatation, you can do any sort of examination subsequently. Your readings will be perfectly fine. But the cases where we suspect dry eye or an ocular surface disease, which may be altering the corneal topography, because the best way to judge corneal power for IOL power calculation is something which is based on a placido disc measurement. That will give the accurate power, which is more important. Unless you are looking for a difficult situations like a post-refractive surgery patients or a little ectasia, then posterior corneal assessment will be required. For routine cases, that is also not required. You just require an anterior surface analysis, and best is a placido disc or a routine keratometer, which we have been using. There, I think, if I suspect a patient the eyes are distorted because of dry eye. So I'll treat these patients for a 4 to 6 weeks if possible. Then repeat that, and you may have a correct orientation of a corneal topography. And cases which we talked about, which Nilesh also pointed out, if you have a peripheral or a problems like a patient with ectasia, a patient with a corneal scar, these cases as such are a poor candidate for toric IOS. In such cases, if I feel I have to put toric lens, then I'll look for a central corneal power rather than looking for peripheral, because that is the area which is going to be a refractive area. And we'll have some sort of accuracy in these cases. So that is how we can decrease the toricity, and subsequent glasses or spectacles will be less dependence to these patients.
Rajiv, your comment on that?
Yeah, I think I was just trying to say something on lines that Dr. Titial just spoke. See, when we have a case of moderate to severe dry eye, it's best to stabilize the ocular surface before taking up the case for cataract surgery, be it the biometry or the intraoperative period. What we are forgetting is that in the post-operative period, these unhealthy ocular surfaces are going to give you a major problem if they are not controlled from day one, much before your biometry. So let's not jump to the biometry first. These cases need to be stabilized, be it punctal plugs, be it drugs, be it anti-inflammatory agents or whatever we need to do, stabilize them, then do your biometry, and then proceed for cataract surgery.
That's definitely the ideal way to go about. But, if you're a solo practitioner, as Dr. Muscati was telling, won't you lose your patient if you wait for such a long time?
I totally agree with Dr. Muscati. The sentiments behind his statements are completely well understood. But if you want to classically teach someone how to take up a patient who is a moderate to severe dry eye, it would be stabilization of the ocular surface and then consider doing biometry before your surgery.
Actually, there was a similar question in those lines, what Professor Titial sir was telling. There was a question that how long would you like to treat the patient before, final biometry, if you have to treat.
Rajesh, there is an algorithm. There's a very simple algorithm that we all know. One step to the other and then to the other, and what to do in the next step. So follow the algorithm, be patient, because say, okay, even if you manage to do the biometry and it's right, you have an uneventful surgery. And in the post-op period, you have SPKs and you have these corneal ulcers developing, and that puts you deep in the hole. So I think we need to look at a much bigger picture and suggest the right things to be said in a forum.
Let me give an example. I operated one lady just last week. We do a Monday, Thursday surgery. So it was Monday surgery for her, and put a panoptics for her. Based on her biometry, everything was all right. And post-op, she had a refraction of +1 and -2 still, and vision was 618. And she was very, very disturbed. Then we checked the ocular surface again, and the entire ocular surface was totally distorted post frequent medication in this lady. And I said, okay, don't worry, things are all right. Be on our frequent lubrications. We decreased the steroid drops in this patient. Within a week, she came with just +0.5 and -0.5 SIL. And she was quite all right. So what Rajiv is saying, like sometimes we do miss these patients which has a mild, a dry eye, and which gets accentuated by a frequency of drop which you are putting for these patients, multiple drops, and they all have preservatives. And suddenly you have a totally, disrupted ocular surface. So that part, again, the fluorescein thing comes here again. So if you put a one fluorescein drop, that will tell you what has happened to ocular surface in these cases.
But very often what happens in the pre-cataract patients, before working them up, we don't, put fluorescein. We just try to analyze.
That is true. That is.
I think what Dr. Reddy said is very, very useful, that we are used to numbers which are written on the cards and the papers, and we really don't see the analysis which should be, seen on the screens, or at least taught to the optometrist on the screens.
And particularly these patients may not have problems when the pupil is small, but in the mesopic light conditions, they will have quite severe problems.
Mm-hmm.
What I like to use in some of these patients, especially torics, is to subject them to the eye trace. And because it has these 256 points infrared beams, and I don't know, it tells us the corneal component in a separate way, especially the regions, how visually significant they are. it's an expensive machine, and for us to have it. And just one thought, and for the comment, do you think it will make a difference if we use two machines and maybe patients have not been blinking, there's some error, and we just kind of combine it?
No. What was your question, Amit?
Your voice,
Yeah,
your voice was not clear.
What I was saying was that one is that we can do eye trace on some of these patients where we suspect the corneal component is, in some way involved. And just a thought which just occurred to me that, person is doing, sometimes patient is just staring, not able to focus. Maybe we can do on two machines where we have a doubt. I don't know, it's not practical, but sometimes we can try it in these patients. So if there's a difference in the biometry with two machines,
I think, Amit, your point is absolutely well taken. Sorry, Namrata.
Yeah, no,
Point
fine.
is absolutely well taken. As far as biometry is concerned, we all agree for a premium IOLs, toric or a trifocal, multifocals. Keratometry is one of the major thing here, and people would suggest you use two instruments for getting a corneal power check, and especially look for a amount of astigmatism and the excess of astigmatism. If you, unfortunately, if you don't have two instrumentation, they say, okay, you do a two examination of the same instrument within a gap of some time, and they should be matching. So that will give you some safety for your consideration for that particular patient. But for a toric one, I think it is necessity. You have to have at least two examination with the same instrument in a different time or two different instrumentations. Yeah, Rajiv?
So one thing I'd just like to go back to our previous discussion, and at least personally, what I'm on the lookout for, even in mild dry eye, is a component of partial limbal cell deficiency, because that creates a havoc in the post-op period also. Because these patients precipitate very fast, especially with frequent post-op medications. So I think on the lookout, other than dry eye, you should also have a lookout at the limbal cell status, because even the partial limbal cell deficiencies, they kind of cause a havoc post-operatively.
That may also be the dry eye can also lead to partial stem cell deficiency.
Either way, whether it's primary or secondary, I mean, if the component is there, the healing potential of the cornea.
That may be an indicator that you have to care. Any other comment?
I think there is
just
a question.
one, query for Dr. Reddy, because he has so many good, experience. For a toric IOLs, we discussing toric IOLs. Suppose we have put a toric IOL for a patient, and post-op the results are not as per our expectations. So how would we assess apart from ocular surface?
So we had, it's not unusual, as you are telling the expected results. We do see in our practice almost around 20% of the time, 20 to 25% of the time, the results are not as expected in toric IOLs. So when we had a surprise, we redo the pentacam, and at the same time we have the Placido. As you are telling, still we rely on Placido disc for ocular surface, and for the toricity, orthogonal, all we look at the pentacam. If most of the times what we found is the astigmatism is not orthogonal, and there is a lot of coma. One side it is different from the other side. If they are okay, we are leaving them. I had at least not many patients, 2 or 3 patients who are very terribly disturbed with the ghosting of images, all those things, very real disturbed. We did a wavefront guided LASIK. They are very, very happy. They say, doctor, whether I have the vision for another 10 years like that, it's so beautiful, they say. That's what I learned from Dr. Sealer, Dr. Theo Sealer last time when we were discussing. He was telling that almost 30% of his unhappy patients is doing wavefront guided LASIK post IOL transplant. The coma, he says, is the triphile. These are the two major causes for unhappiness.
I think good point. But if we see the Indian, especially like myself, patients have a better ocular surface at that age group. The Indian scenario, I see that all patients who come in a cataract age group, they all have a very poor ocular surface. And one thing, we don't analyze them appropriately also, and we don't take that step into correcting these astigmatisms. I think Dr. Namrata can comment. She had done a comparative toric IOS versus PRK cases. Dr. Namrata.
Yes, sir. So we had done a comparative study, and I think it was Dr. Ritu Nagpal's thesis, which got published in American Journal of Ophthalmology, where we had done a comparison of toric IOL versus phacoemulsification and toric IOL versus
Yeah.
phacoemulsification, and in the second group we didn't put toric IOLs, but whatever the residual astigmatism was corrected with the PRK. So we found that the results of both the in both the groups, the results were comparable and were good. And in fact, what Dr. Reddy is saying, the cases where we done laser also, they also did well when we compared it with the toric IOLs. At that time, of course, sir, we didn't have eye trace, so we didn't do the higher order aberrations. But I'm sure if we repeat that study now, we will have findings in terms of aberrations also.
Any other comment?
Sir is
Just one
muted.
more question to Dr. Namrata.
Yes.
Because you see a lot of patients with SJH and severe ocular disorders. So how do you have done a lot of work in auto serum and cord blood serum also? Would there be any comparative studies for future, like HAs being used so commonly for all types of dry eye nowadays, with combinations also? How would HA fare in these cases with HAs and severe ocular surface disorder?
I think HA has come as a boon for these patients, because earlier when so many HA preparations were not there, we were just giving them our routine CMCs and HPMCs. So that way it has come. It is found to be very effective because it gives a lot more wetting ability as opposed to the CMCs and the HPMCs. So it is good. It gives a far more symptomatic relief as compared to our plain drugs, but we've not done any comparative study, and I think there would be many, but not in this subset of patients, and it would be worthwhile comparing in these extremely dry eye patients of ocular SJS and chemical injuries.
Yeah. Okay, just one query, Rajesh. Most people sitting here, they do refractive procedures. So which is their preferred lubricants post refractive procedures? They can give one by one.
Yeah. We can start
JK?
with Dr. Reddy.
Yeah, my HA only is my preferred for a long time.
HA only. Rajesh?
Fresh.
Well, initially it was CMC, but now it is a combination of CMC and HA is a very good option.
Okay. Dr. Amit?
Yeah, I would agree with Dr. Rajesh. I think same. Now it's a CMC HA combination. Earlier, I used to give CMC.
Okay, Rajiv?
HA, sir.
Sharma ji, Namrata ji?
Sir, I think we all are agreeing with Rajesh at this point in time.
Okay, what about Bhaskar? Can
Bhaskar,
you
you have
unmute
to
yourself?
unmute Bhaskar.
So as SN, we have a protocol of we are using CMC only unless the patient was on some kind of tear supplements before the procedure and was a mild dry eye and we've done a PRK kind of a thing. Then he continues with whatever lubricants he was using. Otherwise,
Okay.
CMC using, right?
I find that really it doesn't make so much difference. These are young patients. These are not severe dry eye patients or anything like that. And if they've not been on dry eye or they have not been dry eye patients pre-op, then it doesn't matter. Whatever you use in about 2 weeks or 3 weeks time, they are very comfortable. So you can use HPMC, you can use CMC, you can use HA, you can use combinations, you can use your HP Guar and PEG PG. It really doesn't, because I've tried all sorts of 20 years, 25 years, we've been doing refractive surgery. We've gone through the gamut, right from nothing available except your Moisol drops, which we had, to now. And really the difference is there's no wow factor. I mean, not that I would use Moisol today, but I'm sure if I did use Moisol on my patients, there would still not be too much of a complaint. It's that 5% of patients in whom you have an undetected dry eye which has somehow slipped through. in those, your actual choice of lubricant will really matter. But for the garden variety of your LASIK or PRK, it's nice in a forum to speak about all the other lubricants, but it really, to me, doesn't make so much difference.
Okay. Let me get back to Dr. Bhaskar here again. Suppose we have a patient post LASIK or post PRK, and we think it's a lot of talk on nerve regeneration in these cases and inducing dry eye. In such cases, which type of fluorescein pattern will be seen in these cases, and what would be the preferred medication?
The problem would probably be a little bit of epithelial healing issues, especially if at the edge of the LASIK flap, you might get a breakup earlier. But that's more because of the profile of your tears, and the tear resurfacing will get affected because the corneal contour gets changed by the procedure. So you will probably get a wettability related dry eye more often, unless you have the Schirmer's being less because of a pre-existing or a missed out dry eye pattern as such.
No, one thing is the immediate post-op, which Quresh has nicely highlighted. We have a patient 3 months post-surgery, and patient has now the dry eye features, and we presume that is because of the nerve regeneration not been there, and they have some sort of inflammation attached, and now they have. So, what would be your preferred way to manage such case?
So then the only thing that we have probably right now is cyclosporin, which does help to some extent, apart from the nerve growth factor, which we don't have access to, and I don't think Indians will be able to afford.
I would be very aggressive in my management of a patient that Dr. Titial has said, who's 3 months out and is still got dry eye. I would analyze him and perhaps put in punctum plugs as well, and do whatever we can to improve this. I might even use autologous serum for these patients, because again, these are all young patients who shouldn't have dry eye at 3 months. So we need to supplement this in whatever way possible.
Sir, I think
Yes, you are right. But if you listen to talks of Rohit, he talks always on inflammation and inflammation creating.
I would use cyclosporin as well. I would use, like Bhaskar says, I would use
everything. Namrata?
Sir, you've done a study on cyclosporin versus chloroquine eye drops. So did you find any difference between the two?
Definitely. We just finished that thing. It's now under writing. So in cases undergoing LASIK and SMILE, we started cyclosporin before surgery in these cases for all routine patients. And we subsequently seen these patients for 3 to 6 months. And people who received cyclosporin right from the beginning, they fared remarkably well than a patient who never had a cyclosporin. So in fact, after this is analyzed, so we are going to make a protocol that you might start cyclosporin in all cases, because their ocular surface, their visual complaints, and was definitely far better. And we did a MMP9 study for these cases also. That was also better.
So what about chloroquine eye drops?
One group was chloroquine in this also, and chloroquine was slightly inferior to cyclosporin in some of the parameters. But if you compare the visual parameters and the Schirmer value, other value, they are almost equal. But if you look into a tear film breakup times, tear osmolarities, and the inflammatory marker, cyclosporin fared better than a chloroquine than a control group.
Even did you compare hyperopic LASIK versus myopic LASIK?
No, they're all myopic. We didn't take a hyperopic because their ablation is bigger and the flap is also larger. A number of cases would be less also. So we didn't take that. We just took a myopic and compared myopic patient.
That how do the hyperopic LASIKs behave as compared to myopic LASIKs in the post-op dry eye? Because their whole contour is completely different. The flaps are bigger, the ablation zones are larger, and there is central steepening, which is far more difficult for the ocular surface to handle. So it would be an interesting study. I mean, you would have enough numbers.
That is true. No. We also don't have enough number. We have very few hyperopic patients.
Hyperopes are very few. Hyperopes are few.
And that's why
where do you think Liftegrast, which a couple of companies are trying to market, including Novartis and including Microvision and including Ajanta Pharma, where do you think that will fit in? Will it be comparable, or will it be competitor for cyclosporin?
I'm not sure. Maybe it is a competitor to these medications, unless we have some sort of a case
it will
control
be a
study.
competitor for cyclosporin because it is basically an anti-inflammatory drug. Yeah.
What I'm understanding from its use in the US is that it's largely being used where there is a contraindication for cyclosporin for some reason. Either the cyclosporin is either ineffective, or the patient is allergic to one of the components, or there is too much of stinging, where the patient has dropped out of, and there is a good 18 to 20% dropout rate because of the adverse effect of stinging. So there they are using this drug. Otherwise, the primary drug, I think, it's cyclosporin everywhere.
I think we should talk about diclofenac and sodium hyaluronate also, because we are on a sentence webinar. Although
They should introduce it here first.
we have to push Centent to get diclofenac first to us. Then we'll talk about it.
Yeah.
That is
What
true.
happened to rebamipide? Why has it disappeared, Kuresh?
So rebamipide is available in Mumbai. It's still available. I am still using rebamipide. Some of my patients have been on it for quite some time. It's still available. I find good results with it. Most people seem to disagree, but I find that it does seem to work in quite a few, 50-60% of the patients. It does seem to help. As an
does the house agree with rebamipide?
It does cause a lot of hyperemia, but
yes,
hyperemia and tightness of lids. That is the complaints that I found out in.
I have to use it along with other lubricants. It's never a standalone.
Yeah, absolutely.
Correct.
So it was a wonderful interactive webinar, and I would like to thank one and all. I would like to have the concluding remarks from the president of ISCRIS, Professor Titial. Sir, please.
Yeah, I have a similar opinion, Rajesh. We did have a terrific presentations for all the speakers, and we all learned something. I hope that people who were logged in today, they would have also had some important addition to whatever they are doing for such a common disorder, dry eye and ocular surface. As Dr. Reddy talked about, it's not only the cornea as such, it is for IOL surgery, cataract surgery, name any surgery. Ocular surface is the important part. You might do a squint surgery, you might do retina surgery, you may do a plastic surgery. Ocular surface has to be preserved and improved to have better outcome. In that way, I think today's session should give us a lot of thoughts. It's not that you do your surgery, forget ocular surface. That is what we have to learn. And as Dr. Namrata Samra pointed out, most often we don't see our cataract patient in that point of view. If we start looking ocular surface for these patients, we'll be much wiser, and we can solve the post-op problems of these patients more often with more satisfaction to us as well as for patients. And looking back, I think people can again log in because this will be available, Rajesh, in some other forum. So
yes,
that
sir, it will be
available
on the ISCRIS website.
Good. As Bhaskar said, you can review your videos. Similarly, people can log into this, go through that, have questions. If they have questions, they can send it to ISCRIS website. We will answer them and make further discussion more important for people to understand all these, because we are in treating ocular surface for so many decades, but still things are questionable. We don't still have a proper guidelines for making a proper diagnosis, proper clinical assessment, proper treatment algorithm for these patients, because it is such a compound mechanism for a dry eye, and similarly for a compound mechanism for treating these patients. So I think discussion forum like this, which should have thinking from younger people sitting here to find the proper algorithm for our patients and for our younger generation to treat these patients appropriately. I thank all the speakers, and moderation by both Dr. Namrata and Rajesh was wonderful. And the contribution of Rajiv and Rishi has always been healthy for this forum, ISCRIS, or any cornea forum in that way. And they are experts in dry eye as such. And thank you all, Nilesh, everybody. Thank you for being with us. Ajay, you look great with such a background which has a lot of spots. Unfortunately, we don't have those spots in our scalp.
Yes.
And of course, Amit from PGI.
अमित तो ऑलवेज वो तो डार्क में बैठा हुआ है बोल भी धीरे धीरे रहा है पता नहीं क्या प्रॉब्लम है आज
Sorry, sir. I'll try to improve on it next time.
So a big thanks to all of you. Thanks to the
Thank
support
you.
of Bageshwar, Anil, and of course, big thanks to Santin for supporting this webinar. Thank you very much.
Thank you, Sunil, for the
Sunil.
audiovisual support.
Sunil for the audiovisual. Yeah.
all people who are behind the scene also
Yeah.
because
And thank you all who have attended.
naturally they should come back to with the questions. That is how we know people have got something or not. But luckily things are available on the website. They can again log in and ask questions.
Yeah.
Because this is a subject which everybody wants to know something. Because nobody is perfect in this.
Yeah.
Because if you have one dry eye patient, you're pretty sure that patient comes back to you after 1 year. The patient would have visited 10 people in that period of time.
Okay, sir. Thank you.
Thank you, sir.